Hi, everybody. Welcome back. My name is Rebecca Griffith, and I am the EDDPT, and you are here for our next episode of Admitted or Not. And I just want to give my standard summertime disclaimer that my children are home for the summer and could come bursting through this door at any minute in any state of happiness, sadness, or need. So I apologize if that happens, but it'll just add to the drama of everything we've got going on. And today I have with me Ashley Licursi, who is a physician assistant in the emergency department. Welcome, Ashley.
Hey, good morning.
Do you want to go ahead and introduce yourself?
Sure. Ashley, I've been a PA for almost 10 years now, 6 of which has been in the emergency room. And then I did some high risk OB-GYN and urgent care type stuff as well.
Great. How did you become a PA? Like, what brought you to that role?
So I took a very circuitous route to being a PA. I was on the fast track to medical school for my entire life. And got into every medical school I applied to, and then decided that I wasn't quite sure whether or not that's actually what I wanted to do. So I went and got a master's degree in anatomy first, and decided that maybe being a PA was a better route for me. So applied on a whim and got accepted and never looked back.
I didn't know you had a master's degree in anatomy. That's cool.
I do. Technically, it's biomedical sciences, but I focus on human anatomy. Yeah.
That is very cool. So for people who may not know, what is a physician assistant?
So people call it a physician extender. I essentially function like a doctor without as much training as they have. So I have a tight working relationship with whichever of my attendings happen to be on that day. I tend to run my cases by them if I have questions, and vice versa. Quite honestly, they'll run their cases by me if they have questions. It's really just a jointed practice.
So physical therapists have something similar. It's called the physical therapist assistant. And the difference in that case is that the physical therapist assistants are, I guess you could say, a little bit like a physical therapist extender, although they can manage a caseload of patients, they just can't evaluate or set a plan of care. So in some ways, very similar.
Yeah, I mean, I create a complete plan of care. I can prescribe meds, I order and interpret labs, imaging, etc. But really and truly, the buck does stop with my attending. So very rarely do we not kind of see eye to eye. But if we don't, the buck stops with them. They have more training and education, and I oftentimes will defer to what they want to do, but that happens pretty infrequently for us.
So in the emergency department specifically, like what made you consider emergency medicine?
I do not love to see my patients multiple times. That sounds awful. I like the acuity, and I like the variety that I see every day. It changes. I'm not walking in with a schedule where I can look down and say, oh, I'm having 3 well child checks and 5 physicals. I don't want to do that. That to me, well, somebody's niche is not mine. And I really do like the acuity of the patients. They're there most of the time because something is really going on that they need help with, and need help with it now most of the time.
I think you and I are very similar that way. Like one thing I learned as a physical therapist when I started was that I really enjoyed developing those relationships with my patients. But then over time, I felt like I was carrying a lot of grief and sadness with me from my patients. And I worked in a very different setting. I worked in a brain and spinal cord injury setting. So all of those patients had undergone some kind of trauma, some kind of life-changing trauma. And I felt like really I had trouble separating work from home. And particularly after I had kids, I felt like, gosh, like I need a job where I can come in and give people the best that I have that day and then let go and not see them again. And so I just assume every patient that I see in the emergency department is doing great. They came, they saw me, they are doing fine, their life has continued happily ever after. And then I am excited to meet the next patients the next day.
Yeah.
So I like that too.
I like being able to, at the end of the day, be done.
Yeah.
I mean,
Yep.
I don't follow up on my patients. The likelihood that I see you again is very slim. We have a patient population where sometimes we do.
Yes.
But for the most part, like, you're going off on your merry way, and I assume you are thriving.
I love that. And that's one of my favorite parts about that too. I do occasionally miss kind of that relationship developing with patients and seeing like what happens next. But I think for me, again, just like you, I really like the variety, and that we're not just like seeing patients with knee pain 3 times in a row or patients with back pain all day long. So I like not knowing what's going to come next.
Are you there?
I'm there. Are you here?
Oh, there you are. I just texted you. I was like, you're frozen again.
I think it's you, because I'm still talking and you're freezing up on me, but that's okay. We're going to make it through.
Oh, well, I was still talking and you were freezing on me. So.
Well, we'll see how it goes. So you and I pretty much started in the emergency department around the same time.
I think so.
Yeah. So you've seen an emergency department physical therapist practice start, develop, and more recently grow. So what were your initial thoughts when we started having physical therapy in the emergency department?
Oh, thank God. Look, I am good at a lot of things. This is not one of them. I am not great with musculoskeletal back pain. I am not great with vertigo. The number of things I am not great with that you guys are is expansive. So I have been very excited to see our EDPT program grow, and especially the new kind of expansion has been lovely.
What would you say that you feel like the pushback was when PT and the ED started?
I just think that it's fear. Like, I think that it's attendings, any provider really, if you're uncomfortable or you don't know somebody's skill set, or you're unclear as to what they might provide, like, you have trouble giving up control a little bit. Yeah. And once you really build a relationship with somebody and you know that they know what they're doing, like, feel free, go forth, do all the things, please.
Yes. Because I think when we started in the emergency department, there was kind of this like, we don't really know you. We don't know what your skill set is. We don't know if we can trust you to make the right decisions for our patients. But I think once we establish that, then the attitude for me, particularly with different attendings, with residents, even with APPs specifically, is please practice at the top of your scope. Handle all of these things that you can handle.
Please do, and come to me if you see something that you think is odd or I need to address. But other than that, go forth and do better, because I can't do your job at all. So, I mean, on the heels of that, I find that you are very respectful and responsive when we say, hey, like, I don't like how this looks. This doesn't look good to me. Like, I remember one time when you and I were sharing a patient, and I went in and evaluated the patient, and I was really concerned that he might be having stroke. And you went back and you were like, no, like, he was doing fine. And I was like, yeah, but like, no, he's not. And we went back in together and we were both like, ooh. Yeah. Yes, that gentleman got TPA. Yes. And you were like, that is not how he was 20 minutes ago. And I'm like, that is how he is right now. But like, I feel like there are times when it is hard for us to really get the attention of a medical provider and be like, these are things that I'm noticing, and I need you to come and evaluate that. So how would you suggest is the best way for a physical therapist to communicate with an APP to get that kind of second set of eyes? I think specifically saying, because we're not great with the nebulous. Like, if you need me and you need me now, I mean, I have a whole huge list of things that I'm working through just like anybody else. So if it's something that is acute and you need me to come look at it now, actually saying, hi, I really need you to come now and evaluate this. Just saying that, like, oh, patient is having some changes. Okay. Great, I'll add it to the list. Yeah, right. Versus, he's really different and I need you to come and look at this now. It just helps us prioritize in our brain, like, okay, nope, they actually think something is going on and I really need to get off my hiney and go evaluate. Yeah.
Because I think sometimes when we have pushback, I remember when I was initially in the emergency department, there was another patient who was a gentleman experiencing homelessness, and he had had a stroke in the past. And I had a pretty significant concern for a new stroke. And the occupational therapist was with me in the emergency department as well. And she did as well. Like we were pretty concerned. So we let the nurse know, and the nurse came in and was also concerned. And we let the resident know. The resident kind of did a drive-by, was not concerned. And then I was concerned enough, but still like so nervous and new in the emergency department that I did speak to the attending about it. And again, the attendant came, took a look, kind of said, no, this is just like baseline from this previous stroke. And I think at that time, I just didn't know how to advocate well enough. And at shift change, I tried again with a different attending. And that attending was familiar with me and was like, let's get a CT now, call a stroke alert. And we did that. So what I've learned from that experience is to remember I can call a stroke alert. Hello. And this gentleman ended up being fine. So I want to just like add that in. He was fine. He did have a new stroke, but it was very minor and he didn't require any additional treatment. But we are empowered to call a stroke alert if we don't feel like the patient's getting the care they need, that we can continue to sort of elevate that concern regardless of how many times we're told no, because the goal is patient safety, right?
Yeah. And I mean, there are times where the same thing happens to me, where I'm like, ooh, I really think something's going on here. And it's not that I get poo-pooed, but like they're like, I don't think so. And like you just continue to have a conversation about it. I mean, I would, in your scenario, I'd keep pushing until somebody came in and actually like fully evaluated the patient.
Mm-hmm.
And sometimes that's not easy in a really busy emergency room.
Right.
But quite frankly, like the more that we know you, the more, and it sounds awful, but the more likely we are to respond with some gusto. If you come and tell me that you think somebody's having a stroke versus some of these brand new, baby PTs, God love them and they're learning, but it carries a different amount of concern when
Sure.
I know that somebody who is really skilled in what they do has evaluated this patient and it's like, oh, okay, something's not right.
Yeah, I think it was you, one of the PAs that said, I don't even order a pizza unless PT tells me it's okay. And the conversation was about like discharging patients that have a home safety need. So what has been your experience with PTs evaluating patients for home safety? Because I know there are a lot of times where the medical team is like, hey, like they look okay medically. They don't look okay from a life perspective.
I mean, I am not good at telling if somebody is going to be successful in a life perspective when it comes to being discharged home with X, Y, or Z medical diagnosis. I will always defer to what PT says. I have no horse in that race. If you tell me that this patient is not going to thrive at home because of mobility issues or safety issues, then we will find another alternative.
I think that's fair. I mean, because it's really one of the things that we specialize in, right?
You know it better than I do. I look at them and go, they kind of got to the bathroom okay. I call that a win.
Yeah. And sometimes we're like, thank God they made it to the bathroom okay just then.
Yeah.
But I think the other thing is too, like taking into account all of the factors that patients have to face when they come home. And I find, maybe this is a little bit of a personal bias, that sometimes members of the medical team specifically don't consider those factors.
No.
And that you've met your checklist and everything on the checklist looks good. And I'm like, yeah, but like this person's weight bearing on one extremity and has 32 stairs. Like, what do you suggest?
I don't even, like, only recently and after having known you have I started to like ask these questions. Oh, you have a humerus fracture, but wait, you use a walker.
That's a problem.
That's not going to work. Like, that's not something we're taught in school. It's not something that is inherent in our education. So, I mean, until I started working with you, I didn't really think about those things, quite frankly. Now I do.
What are some things that would go the other direction, like that physical therapists aren't considering from your perspective? like, I know sometimes it's like we need to get patients out of the emergency department, and that we're maybe like too conservative, or like what are other things where we should come get you that we're not?
I mean, turnover, like going through patients in the ED, especially given the state of the pandemic, is always a concern, right? I have limited space, whether that be if you're seeing a patient in the observation unit or if you're functioning independently in our urgent care type arena. Like getting patients moved through is exquisitely important. Now, not at the expense of their safety, but like I don't find it to be a problem with you. But yes, there are some PTs that are overtly cautious. And it's probably just because like your risk tolerance is different than their risk tolerance. The same thing applies with new PAs. Like my risk tolerance, I'm like, oh no, they're fine. Send them home. So I do think that sometimes there is an overabundance of caution. Excuse my cat. It's just what he does. And I think there is a little bit of, I don't know if I'd call it fear or hesitancy to come and like bother the provider. If there is more so among the newer PTs, they don't want to bother me with their questions. They don't want to bother me for a sign out on the patient. And I'm like, you're not bothering me. You're like doing the important stuff. So feel free. Like, yes, obviously, if I'm like, I don't know, dealing with a stroke alert, no, now's not the time.
Right.
But I just feel like people don't want to bother the provider, and you're not bothering me. You're like helping me.
Yeah, so the context about that is like other areas of acute care physical therapy are not as collaborative as the emergency department. So PTs that are coming down from other areas in the hospital, like their workflow is often to speak just to the nurse, and then they document their findings in the chart. They may never speak to the PA, they may never speak to the provider at all.
Which blows my mind.
I know, and God forbid if you page the wrong physician, I mean that's also a problem. And it's not a problem from the perspective of that's the workflow and that's the hierarchy and that's how these things get taken care of. Because there are so many patients that if every attending in the hospital were to talk to every consultant or every person that goes into that patient's room, I mean I don't know how they would get their job done. So there is like an order of communication that happens in the emergency or in other floors of the hospital, but
yes,
it is very different in the emergency department. So we are kind of taught like not to bother the providers, even though we are one. And we will if we need to, right?
Well,
like if there's something that's not routine. But the other thing is most of the time those patients we're evaluating and then making recommendations, and that patient's maybe not leaving that day. So the recommendations that we're making for patients in the emergency department, they really are leaving urgently. So I think that communication definitely has to be expedited.
Well, and I mean, honestly, we work very closely with you guys too. Like,
yes,
it's not like I don't know each and every one of your names and your like what you like as your coffee or Diet Coke order. Like, yeah. I mean, so I think that does, there is a little bit of a difference there between the floor and like us. I mean, the other thing is like, we're all trying to get to the same endpoint. Like,
yes.
I mean, I'm never that busy. And if I am, interrupt.
But that's one of my favorite parts about being an emergency department physical therapist is that camaraderie and that team. And in the emergency department, I am treated as a consultant, like with an equivalent opinion. And yeah. I remember an incident where I spoke to a resident. I was concerned about the way that the patient's care plan was going. And I think for me, I've stopped thinking of like residents as these like physicians who know everything. And I'm remembering that they are physicians who are learning and that they also want to learn more and that they know that that's the stage that they're in. So I've started just, like gently helping them with their care plans. Like, hey, like, why are we doing this imaging now? And I've had nothing but support from like the attending physicians who might say, Dr. Griffith has questions for you about this care plan. And being like, having that physician lead by example for how to treat the physical therapist, as well as like sharing what our knowledge level is and our educational level so that they know that we have like the experience and the knowledge to kind of back up the care plans that we're making.
Well, and like sometimes in the ED, we're so busy that we image,
Well, 100%.
right? Like
Yep.
I think there's a problem there. I'm not entirely sure, but I have 10 other patients. Well, the easiest thing for me to do is throw on a CT scan while I'm waiting for X, Y, or Z. And I'm not entirely sure what's going on.
Right.
So I'll put them through the donut of truth and like. See.
Okay, I'm totally going to call it that forever. But I would argue that it's maybe the donut of maybe.
I mean, yes, but it's the donut of maybe for me, but it's going to give me the truth.
Maybe, because sometimes it gets you absolutely nothing, right?
Which tells me that it's not an emergency and I can be
you can stand down and then our work can begin, right?
Yes, exactly.
All right, I'll take that. So what would you say to different hospital systems that might be considering adding a physical therapist to their team?
For the love of God, please do it. I mean, I obviously have not practiced. I mean, it was a baby program when I first got there. So it's different from when it started to now. So I have some experience of being in the ED without a PT, and I do not prefer it. I find that you bring a level of care to the team that we cannot. And it's better for the patient. And like, I'm not going to fix somebody's like back pain and you make them walk out of the ER. Like,
I love it when that happens.
Oh my God. I'm like, yes. It happened on Sunday. I was like, thank God. I never would have fixed that.
Like, well, and hopefully that like the other thing that we can offer that sometimes can't be offered by other providers in the emergency department is the time and space to listen to a patient and the time and space to really hear what other providers have not. So one question that I often ask patients is, what do you feel like no one is listening to you about? What do you keep saying that no one is hearing? And oftentimes it can be really important. Like we had one patient who I was consulted on to see for a fall, and it was a mechanical fall. Can you please evaluate the patient? And while I was talking to her, I said, hey, like, tell me about who's helping you at home. Because what I have in here in your chart is that you live with your husband. So tell me about that. And the patient just started crying because her husband had died 3 weeks earlier. And she was alone and she wasn't eating or drinking anything in her grief. So she did not have a mechanical fall. She passed out because she had low blood sugar. And that was information that I could provide to the team. I also was able to consult the social worker. We were able to call her children and have them come like rally around her because they didn't realize, like for them, she was the matriarch of the family and she was just fine.
She was doing fine.
But she was hiding that grief from everyone, including the physicians. So being able to take that space and my whole intervention in that case was to sit and hold her hand while she like had her feelings.
I find that patients sometimes have a fear of disappointing us, which I like.
Yeah.
You're not going to disappoint me. I just want to help you, whatever it is. I mean, I tell my patients, this is like Vegas. What happens here stays here. Like, if you're telling me that you're an alcoholic and nobody knows that, like, let's find a way to make this better. If you're telling me that, like, you know, your husband is harming you at home, let's cross that bridge. Like, let's figure things out. But patients often are fearful that they're somehow going to disappoint us by telling us the wrong answer.
Yeah, I think sometimes patients are embarrassed to tell you things too. What I've found in our like fast track or our urgent care area of the emergency department is what they tell the physician and then what they tell me about how they got hurt is very different. So I'll have a physician say, well, the patient was lifting a heavy box and they strained their back. And I'll talk to the patient. I'll be like, well, really, like, what were you lifting? And they're like, well, it was actually a sex-related injury. And they just didn't want to tell the physician that. Or I had a patient the other day who was concerned about not being able to go to work, but what they were really concerned about was, in fact, sexual positions that would give them less pain, and their partner was with them. And so there I was in the middle of the urgent care type area of the emergency department, counseling them both on the best sexual positions for the type of injury that the patient had.
Yep.
And the like relief from both of them was extraordinary. They were like, well, we can manage that. Like we can do the physical therapy, we can do these stretches, and now we can kind of stay connected in our relationship as well.
Yeah.
So I think that sometimes it's just, I don't know if it's because we don't come across the same way, if it's because we touch patients and we are more familiar with them, we spend more time with them, we ask them about how things are going at home a little bit differently, I think.
Yeah. I mean, like I try, but it's definitely a different interaction.
Yeah, I think we just kind of get that experience over time of like how to ask those questions, where versus like, I know that you can get a medical history out of somebody like that, and you know what kind of medications they're taking, and you know if they've had a stroke before, and you know which hand like doesn't work well, but I know how many stairs they have, what kind of bathroom they have, who lives there, and who picks them up from school, like a lot of the things.
Yeah.
And those are the things I don't forget about patients. I won't remember your name, but I will remember how many flights of stairs you had and what your cat's name is.
Cats' names, dogs' names on it.
One of my favorite charts that I ever read was like a patient lives with son, daughter, and 3 parakeets named like Bosco, Rocky, and Steve, as well as a pet horse named Bailey. Like the physician had named all of the animals, but none of the humans.
I mean, these are
pretty awesome.
These are important things.
I think so. I also saw one that said patient is unusually handsome, and I was like,
I don't know that I would use that one, but yeah, each their own.
I wondered what was so unusual about it, but we may never know.
Or the scribe typed something incorrect.
Yes, I had a consult for a patient for a perineal nerve dysfunction that was causing a foot drop. And I said, a perineal nerve dysfunction? Like, I'm not the right kind of PT for that. My pelvic health colleagues, they've got you. I'm not going to do that in the emergency department. And so I said to the physician, I said, how did you test for that? He said, well, we just, we did like muscle testing. I'm like, yeah. And then they looked at the chart and they were like, oh, no. Peroneal. So sometimes I think those errors are the funniest, but I have had one issue where a scribe actually charted that I recommended the discontinuation of a blood pressure medication. So, which is obviously outside of my scope. Non-pharmacological management of blood pressure, count me in. Pharmacologic management, count me out. So
not so much.
Always,
we discuss it, but like as a jointed like conversation, as what can I add to this that you need.
Well, I think that's another great example of how physician assistants and PTs can work together. If I'm evaluating for a patient for low back pain, and I can tell you, I think this is a disc issue, I think this is a nerve root issue, I think this is a muscle related issue, I feel like that helps guide you in what might be the most appropriate pharmacologic approach.
I mean, there's a big difference between, Nana, who has severe osteoarthritis, and a 34-year-old guy who has disc injury. I mean, the medications I pick are going to be quite different. In fact, I mean, there are medications designed for each of these things.
Well, also like that way we don't have to give everybody a muscle relaxer.
I'm not a fan. I don't often.
I'm not either. And so whenever I say to one of the APPs, I say, hey, I think maybe in this case, the patient could benefit from a muscle relaxer. They're like,
are you sure you just said that?
Really?
You?
Really? I know. This is crazy. All right. Are you ready for the case? You have a case for us today? Our admit it or not case? I'm ready.
Yes, I'm ready.
Tell me.
Okay. So I think I'm trying to think of the most recent one I had. And what is her name? Was it Shelby that was the PT? I think Shelby was the PT on that weekend.
Maybe.
In the observation unit, and Nana, no real support at home. The plan medically, Nana was fine. And at sign up,
Way to go, Nana.
Nana was like medically nailed it. Except as we were getting ready to secure her transport back to home, the nursing staff became aware that Nana has nobody there waiting for her, and she has BKAs.
But does Nana normally function with BKAs independently?
Nana, from what I was told, does. but it did not appear so when I went and met this woman. Um, so we got PT involved, and OT for that matter, because there were just many complexities once I sat down with this patient who was teed up to go home. And PT came, evaluated her, was like, oh, hard pass. Like, she's supposed to be using her wheelchairs. She like doesn't have good access to support at home. Like, she just doesn't have the things that she needs, quite frankly. And if she was my Nana, I feel bad if somebody sent her home. So we kind of just sat and discussed, and like social work, case management. I mean, all of the people obviously got involved, but without any type of support at home, we kind of just shifted and started to work on giving her some options. She was not happy with many of them. She did not want to go to rehab. She did not want to go to long-term care. She did not want any of these things because she wanted to go home. But we ended up getting her all of as much support as she was willing to take. She did end up going home despite my opposition. I thought that home was not going to be the best place. PT felt that home was not going to be the best place. Case management thought that home was not going to be the best place. But she was very adamant. And at the end of the day, she's the captain of the ship.
I mean, amen. So I think that's important to remember, that patient-centered care requires the patient to be at the center.
It is my goal to help you navigate the waters. If you tell me that you're going home and because whatever, you have your puppy at home and you need to be there to help with your animals, then I'm going to give you as much support as I can at home. But at least we caught that before she went home. Like, I feel like sometimes we're really bad and people will have to like come back several times before we like, oh, you're not here for that. You're here for this.
Yeah. I had a patient recently who ostensibly was there for back pain, and he just looked real sick. And I evaluated, like, young guy, evaluated his back pain. I'm like, yeah, like, these are things that you could do for your back pain, but like, you don't look good. Like, what's happening? Well, I just feel like I've been hit by a truck. I just feel bad everywhere. My legs hurt. Both of my legs hurt. My back hurts. Like, everything hurts. I just don't feel well. And every time I would leave the room, he would cover his head and like curl up in a ball.
Oh.
And I'm like, yeah, like, that's not like acute mechanical low back pain. And I came in and out, and the attending was like, yeah, like, I mean, I scanned his belly because like he just doesn't look good. In and out. I finally said to the patient, you're not really here for back pain, are you? And he goes, no, but I don't know how to explain it. I just feel real bad. He had flu.
Oh, yeah.
I said, maybe we should swab him, you know, in the setting of the pandemic. I feel like we're looking a little bit more carefully for things like that. In his case, flu A. I bet he felt bad.
He had a young kid the other day who was a zipline instructor. I didn't know there was such a thing. I'm not outdoors. So
how dare you live in Colorado and say that?
I know. He had a somewhat bigger gal who had clipped into whatever thingy that they clip into to like go down. But because she was scared, she was going to be clipped into him, and then he was going to be clipped in as well. Well, he got clipped into her, and then she jumped. So he was never clipped in on top.
Oh no.
And he dangled 6 feet below her.
No.
Hitting all the trees and rocks on the way down. And he also felt miserable. However, he did have a C6 spinous process fracture, but he was febrile and like sneezing everywhere. I was like, you're really close with patients or your people. You're like strapped into them. So I did not go back and look at his fluid testing, but I am suspecting it's positive.
Oh,
but that
poor
little
guy.
Nugget bounced all the way down that mountain.
Oh man.
I sat there and was like, oh, if I would have done that, I never I'm too old for that.
Yeah, no, that definitely hopefully got a PT consult.
I can't imagine. I mean, I signed him out, but I can't imagine that he was not going to have one.
Oh my gosh. Ashley, thank you so much for being with us today and for
Of
your
course.
collaboration in the emergency department and for making sure that Nana got taken care of and she got everything she needed.
She was so prickly, but I love her.
And on this case, not admitted.
Not admitted.
Not admitted. Thanks
Should've
to
been.
collaboration between the physician assistant, the physical therapist, the social worker, and the case manager. Teamwork makes the dream work.
I mean, she got what she wanted. She went home.
I love it. All right. Well, thank you so much.
Cool.